Okay, so we are recording. That's perfect. All right. So welcome to the first trial on to see if this thing works. So this has been a training we've been trying to do for the last 2 weeks. However, today we're going to make the attempt to do our first recording, our first live broadcast, and training on obstetrics. So this is what we used for the ALS monthly training. However, there is a lot of BLS stuff included in this. And we're going to cover different things you might come in contact with an OBGYN or a delivery type of emergency. All right, so let's get started. Watch it not even work now. See, now it's not working. Stand by. There we go. So the first thing we're going to do talk about is a patient exam. So obviously the first thing we're going to do is the scene size up safety. We need to look at the mechanism of injury or nature of illness, right? That's going to be one of our first things that we look for as we walk through the door. The next thing is the patient sick or not sick? So what do I mean by that?
What do they look like? How are they doing?
How they're presenting, right?
Right. General impression.
General impression of the patient. Perfect. And the next thing we look for is our initial assessment. We correct any life threats. This is our normal assessment. If the patient is bleeding out, is that a life threat?
Yes.
Yes. Okay, perfect. And then we're going to do our focused exam. So what is a focused exam? You guys can chime in too if you want on this as well. But what is a focused exam?
You do a more thorough exam of a certain section. Like if you have cardiac, you check out the chest, palpate it, listen to lung sounds, focus on that area.
Okay, so if we're doing OBGYN, what are we going to focus on?
Probably the pelvic region.
The pelvic region, I like it. Perfect, let's move forward then. We're going to get a patient history and vital signs. So what are you looking for a history? What's important?
How many pregnancies have you had?
Okay.
You ever had a complication in a pregnancy before?
Okay. Are you guys still online with us?
They are. They just took their faces out of it.
Okay, so the face, that's gone. All right. Can you guys unmute for a minute and try giving us some feedback on some of this too? What we're looking for patient history?
Oh boy.
We're unmuted.
You are unmuted, perfect. So what I'm looking for is, what else are we looking for patient history? The group has given some on this side. What are some other important things to find out about the history for an OBGYN or a...
How many births, how many live births, any abnormal births?
Okay. And
So he's basically trying to say para grava.
Yeah.
Exactly, that's what I'm looking for, a paragraph. Now that looks for, what kind? What is that looking for again?
How many pregnancies? How many
Pregnancies.
successful?
What was that?
How many successful pregnancies?
How many successful pregnancies, deliveries, right?
Hospitalizations.
Any live births, right? How many kids you currently have? And another one you want to get on this is how many abortions have you had? All right, whether it be spontaneous or done by choice. Okay, because that's another important factor of this. Why is this important for us to know?
Might give you a clue what type of birth this might be. If it's one of their third or fourth kids, it'll come a lot quicker.
Okay.
It might tell you some complications that they might have had.
All right. What else do we want to know about history? Any thoughts?
What else you want to know about history?
Family
Are they seeing someone on a regular basis? What are they called?
A neonatal.
A neonatal physician?
So we're looking for is have they been receiving prenatal care?
Yes.
That's an important thing for us, because at least they can give us a history of how the neonate, or say the hopefully newborn baby here, will have some information about how the progression has been going throughout the pregnancy.
Mm-hmm.
How about how far along are you?
That's a good
How many weeks in are you? Are you in the third trimester? Or are you at 30 weeks and getting ready to deliver as a premature delivery? These are kind of important factors for us to know, right? Are you full term? Are you not full term? When is your due date? I always ask the patient too, what's the name? You know, try to keep things going pretty well with the family. What about vital signs? What do you expect to see?
Normal vital signs for mom, maybe an increased heart rate.
All right, can you check fetal heart rate? Not really. You take a stethoscope and listen, but
Can't count.
no, it's kind of hard to do. We want to do a detailed exam. So what would include the detailed exam?
Taking a peek.
Take a peek, take a look. Normally, if they're full term and they've had some progression with types of contractions, things like that, they may know how far dilated they are at some point. Like when they see their doctors, they come back, yeah, you're still 2 centimeters or 4 centimeters dilated. You're perfectly fine. You still have like another day or so. They may send you back home. There's some things like that. Or they may be doing a home delivery as well, which we had not too long ago. Yeah, so, I guess the next thing you want to look for is a plan. And then we're looking for like, what kind of plan they have, what kind of plan we have, right? As far as how we're going to treat our patient, where they want to go, make sure they're going to the most appropriate facility. Right, so around here, obviously, UVM is an appropriate facility to take a labor and delivery to. Right? I'm not sure about Harvard Hospital they can handle that stuff. I'm sure they probably can. But there are some hospitals that can't handle delivery. But can Porter Hospital handle a premature delivery?
I sent that to everyone. Basically saying,
What do you guys think?
oh, you're trying a baby in there?
So Mike, what do you guys think over there
Think of what?
about premature delivery? Can Porter Hospital handle that?
No.
No.
So we need to make a decision, especially if you're over here in Charlotte and you get called to go to Virgins for a potential OBGYN issue or OB issue. And you get there and you find out that they're 30 weeks along and they have contractions. And they say, well, I want to go to Porter. What would you do to that?
No. What do you mean?
No.
Could you just take them to UVM?
No. You'd explain to them you do not feel Porter is a appropriate facility, and that due to the circumstances, UVM would be better able to treat you.
Right. So if we can follow our patient exam and do all this stuff, as you can see, will give us the best possible patient outcome. We have to have a good plan in place. All right, so some roles and responsibilities. Obviously, be a patient advocate. Sick or not sick is another important one. Remember the ABCs. Define who does what in teamwork. So if you're responding to a OB emergency and they're saying imminent delivery, you should be telling your crew who's going to be doing what they're grab out of the ambulance, how we're going to place ourselves. If there is crowning, we're going to deliver on site. If there is no crowning, we're going to load and transport. Right? Okay, are we prepared to do so? Please do not do gang questioning. That's a big thing. Like one person asks a question. Usually your crew chief or highest license level would be the one you'd want to utilize to be asking the questions. Listen to the patient, especially if they've had more than one delivery already. They can pretty much tell you when things are going to start happening. They're the best source for you to have. And remember, priority is always patient care. I mean, patient care is always a priority. All right, so let's go through some definitions. What's an APGAR score?
Appearance, pulse, grimace, respiration.
So what's the second A?
Activity.
Activities. Yay. What about Abruptio Placenta? What is that?
That comes off the uterine wall. Is it when it bursts?
It doesn't burst, it comes off, right? Detaches. And is that painful or painless?
Sounds
Okay.
It's going to be bright red blood, and it's going to be very, very painful. That's a very, very painful type of deal. What about Braxton Hicks contractions? What are those?
Those are early ones, right?
Right? What do you guys think? Braxton Hicks.
Is it fake contractions?
Right, the false contractions. They come early and they're actually false. What about eclampsia?
The syndrome of hypertension, proteinuria, and edema in the last trimester of pregnancy indicated by a coma and seizures.
And you just looked that up, or did you actually know all that?
I actually knew all that.
You're the man. All right. What about the top of pregnancy?
We should do Jeopardy together.
When the egg starts developing in the fallopian tubes.
Does it have to be fallopian tube, or is it the most common place?
Outside.
Most commonplace.
Right. Perfect. But it can develop anywhere, right? Right. All right. Meconium staining.
When
Baby poop in the water.
Baby took first poop inside mom.
Yeah.
All right. If you have meconium staining on a patient, you really want to call for a paramedic for those.
Yes, we can use their meconium aspirator.
That is correct. The meconium aspirators, which are basically a little suction device that goes onto an intubation tube onto a suction tube. And we go through the endoscope and we can suction out the airway. That's a paramedic skill. So if you have meconium staining and you're having a delivery, you really want to have a paramedic on board because they can do different procedures. Have you done some meconium staining?
Yeah.
It's a dark color and it smells like feces. What about the placenta previa?
When the uterus covers over the cervix. You can't.
Say it really loud.
I was going to say, it's usually when the uterus covers over the cervix. So
The placenta covers over the
Sorry,
cervix.
backwards. Yeah, it's usually when the placenta covers over the cervix, so the baby can't be
Right.
delivered properly.
And this usually has a slow type of darker bleed. With this, it'll also be very painless. It's not as painful as the abruptio placenta. So more of a slower bleed, darker blood. All right, so you see dark blood and it's painless. Most likely it's going to be placenta previa. What about preeclampsia?
Stage before eclampsia.
I like it. All right, supine hypotensive syndrome. We lay down and the baby is resting on
Depression in the vena cava.
right.
Period.
The blood pressure too
Last year classes.
to decrease. So how do we fix that?
Sit them up or on their side.
Put them on their side, right? On the
Left lateral recumbent.
right or left? Right. I heard
Said left.
too. What about a breech presentation?
I was a breach. Butt first.
Butt first, limb, anything other than the head presented is considered a breech presentation. And then we have to talk about gestate prolapse cord, which is when
Cords around the neck.
wrapped around the neck. And this is the only time that you can enter in the vagina, right? Is when you have a prolapse cord with your hands to kind of support the baby and hopefully move the cord as hard as the baby can breathe. And gestational diabetes.
Pregnancy.
Right. Perfect. So we understand our definitions, so we should be able to move forward from here. Let's talk about gynecological emergencies. So two of the most common chief complaints are one would be vaginal bleeding, and the second one is lower abdominal pain or pelvic pain. This is where things start becoming more important for us to pay attention to. All right. And it's also very common in sexually active women, seeing that pelvic pain. We'll talk about PID in a little bit. All right, so we have vaginal bleeding, some considerations we need to know, and this is tough for some men to be asking these questions of females, but unfortunately, if that's all you have in the back of the ambulance, we need to make sure we feel comfortable using correct terminology and asking these questions, because it's going to mean it could mean life or death for some of these patients. All right, so if they have vaginal bleeding, we're going to look at the amount, right? So how much have you been bleeding? Has it been spotty? Is it different? Does it look like it's full of clots? Is there large amounts of blood? If you're at the house and it's still in the toilet, you want to go take a look at it to see what kind of blood it is. If it's dark, if it's bright red. We want to kind of have an idea of what's really going on. When and for how long it's been going on for. The likelihood of pregnancy. So are you pregnant? They say no. Are you sexually active? They say yes. You're going to say, are you on birth control? When was the last time you were sexually active? These are kind of personal questions, so I wouldn't be asking a lot of these questions with like 15 people around you. I would try to get them alone, or if like a 2-on-1 or a 1-on-1, if you have a female in the group, have them ask the questions first. If you're all male crew, just make sure you're being professional and ask the appropriate questions that are there. Is there any pain associated with this, or any other functions? Are there any other medical problems that you may have? And obviously, there's obstetric history for the gravida para. So we want to find out the number of pregnancies and things like that. Perfect. As far as abdominal pain goes and pelvic pain, we want to look at the OPQ-RST. Yeah, this is going to haunt some people. So we're looking at the onset of when did it start. Any provocation, anything makes it better or worse. The quality of the pain, whether it be a dull ache or a sharp pain. Does it radiate anywhere? On a scale of, I usually put it on 1 to 10. I like using 0 because 1 is still a pain level. So on a scale of 0 to 10, how do you rate your pain now? And then how long has it been going on for? Has the pain been going on for hours, days, weeks? As far as the GYN exam, respect the patient's modesty. So the last thing you want to do in the public is have them drop their pants and do an inspection. The way I look at it is underwear always stays intact unless you visually see bleeding, and then take the underwear off. All right. Note any kinds of discharges, any kind of odors you may smell. These are all different things that can lead to something important. So if I say there's an odor, what could that be, potentially?
Infection.
What kind of infection?
Yeast infection.
Yeast infection. What else? UTI. Right? Is there anything else you guys want to add to that for smells and odors?
What was that last question?
Smells and odors. What that could indicate if you have a smell or an odor in the vaginal region.
Bacterial infection? Did we already say that?
We got yeast infection and UTI right now. True, could be a foreign object. Yeah. All right. Fair enough. Remember that ABCs, vital signs, medical history. You need to palpate the abdomen. Right? Remember there's 4 quadrants in the abdomen. You want to palpate all 4. Remember the umbilical is the center. You want to go above and below. I've noticed a lot of people that go, all right, we'll do the top up here. They go, here's the lower abdomen, but really it's down here. So you need to pull their pants down, pull their shirt up, and go into if they're heavier, move some of the fat around, and actually really palpate. If it's a sexual assault, remember that is a crime scene. So if they are raped of some sort of sexual assault, remember we did document what we've done, obviously, and we need to pass that information along to the nursing staff at the hospital if they tell us while en route, and also notify law enforcement. And also remember minors and parental rights. So since Mike is a protocol guru on this, if you have a pregnant female, 16 years old, do their parents have to be notified?
No.
No.
What? That is incorrect.
16 years old and pregnant, doesn't that mean that she has her, that's like under in the
No.
Vermont state protocol?
That's incorrect.
Her parents?
They have to be, so it's either they're 18, if they're under 18 and they are not an emancipated minor, they still have to inform the parents.
You should check your.
I'm very confident in what I'm saying.
Where does it say that in the protocols?
And
I thought.
Mike,
None of that. She still has to be treated.
and they already
The treatment is under parents' provision.
I thought that if you were pregnant, it was.
The mother,
need.
when the baby is born, the mother, so that 16-year-old, is in charge of the baby. But the mother who's 16 is not in charge of her own medical decisions. That is for her older parents. That is how the protocol is.
Welcome to Vermont.
Makes no sense.
Welcome to Vermont.
That is.
It's
Yeah.
a little bit different.
Very dumb.
Mother's
Wait, so the baby, so the baby in the womb is not responsible for the baby's care, but the patient's parents are responsible for her care?
Correct. So if baby is still in mom, Mom is responsible and able to make medical decisions on her child.
But not
Right.
herself.
If
But not herself.
herself, correct, her mother or her parents are responsible for making medical decisions for the 16-year-old, the 16-year-old can only make medical decisions for her unborn child.
So
And-
That is 100% correct.
16-year-old
Ridiculous.
is about for themselves, but capable of making decisions for another person.
That is correct, based on Vermont protocol.
Say that again?
All right.
OB emergency.
So we have parents of the 16-year-old, right? And then we have the unborn baby. The parents make medical decisions for the 16-year-old, their child. Okay. The 16-year-old who is currently pregnant with an unborn child can make decisions for the unborn child only, not for herself. Is that correct, Mike?
Say that one more time, Kevin.
The 16-year-old only has medical decision-making rights for her unborn child or born children.
That is correct.
And the 16-year-old's parents, unless she's emancipated, correct?
Correct.
The parents make medical decisions for that 16-year-old or 17-year-old until they turn 18.
Correct. So that can bring up an interesting discussion, Kevin, that was brought up here. So what happens when the 16-year-old is in pregnancy, about to go into labor, but her parents, who are however whatever age they are, say, "Oh, we don't want her to get treated." What happens then? And that was an interesting topic that was brought up here by Nick.
Okay, so
And it's all about convincing. So you would have to treat in the labor and delivery. Okay, so you'd have to help with the delivery process because that's what the 16-year-old wants for that child.
Yeah.
But if something happens to the 16-year-old,
during
you gotta
delivery,
listen to those parents. So that's kind of that's where the issue happens.
right. Now, in the hospital setting, however, though,
That's a different story.
right, because in the hospital setting, doctors have attorneys and lawyers that can pull parental rights,
Correct.
which we can't do. But in the pre-hospital setting,
Can you put them into police custody, protective custody?
honestly, if this case ever happened in the field, the first thing you should be doing is contacting medical control.
Yep.
On the phone with them and let them know exactly what's going on, and that way they can make decisions. And they have big money and big attorneys in the hospitals that can make things happen right then and there with judges on the phone, so they can pull parental rights and things like that because for the best benefit of the patient.
But I mean, if you say like that's happening, but for some reason medical control is just like busy or just doesn't have time,
Medical control will always have time to talk to you on the phone.
but can you put them into protective custody by police and then be able to treat the child, the 16-year-old?
Depending if it's life-saving measures or not, I guess. Once again, medical control will have to be contacted. I don't have the answer for that one. Nor have I ever run into that problem. In the 18 years I've been doing this job, I've never run into that issue.
Yeah, an interesting issue. Not good for the kid.
So some differential diagnoses for you to look for as far as for GYN stuff would be is pelvic inflammatory disease, vaginal bleeding, sexual assault, ovarian cysts, cystitis, ectopic pregnancy, and spontaneous abortion and miscarriages. So we're going to get some of those. So here's scenario number one. What I want you guys to do is work together. All right, I'm going to step aside from the camera. I'm going to read you guys scenario number one. And I want you to tell me what you think is really going on here. And we'll work through our different assessments. So dispatch to a 23-year-old female complaining of sudden onset of severe abdominal pain with radiation to the right shoulder. That is your scenario. What are we going to do?
Team safety, BSI.
Okay. What else?
You get vitals and patient history.
Okay. What else do we want to know?
General infection.
Anything else you guys want to add to it?
Is she pregnant?
Is she pregnant? Okay. Yeah. Is she pregnant? What else?
Never mind.
Any cardiac history?
Yeah, she had a heart attack.
Still something to think about, right?
A little radiation to the right shoulder, so it's kind of odd.
Okay. What else would cause radiation to the right shoulder?
Could be referred pain from a gallbladder disorder.
Okay, referred pain, right?
Yeah.
All right, so let's go over here. So patient care obviously is position, comfort, reassure and provide emotional support. Obviously, vital signs need to be done. We're going to control some bleeding. Oxygen therapy if needed. Do not give anything in my mouth, okay? Nothing in my mouth at this point because it's an abdominal issue. If there is sexual assault, please notify PD. And don't forget about medics. We're kind of bored sitting around here, so we kind of need to go and play a little bit. So invite the medics for things like that, especially unexplained abdominal pain in a female.
If she was nauseous, could you give Zofran?
Yeah, when there everything is over at all, that's not going to hurt the child. So, if there is one. So, what are we thinking at this point in time now? What's going to be our clinical, I don't say diagnosis, but our treatment plan? What are we treating for?
Ectopic pregnancy?
Okay, is that what you're thinking right now? What else? Anything else from you guys?
You're looking at whatever patient care should be provided.
Yeah. Well, not patient care so much as what is our working diagnosis at this point?
Working diagnosed, bleeding control, oxygen therapy, nothing but that.
Here's our scenario number one.
Thank you.
What's our working diagnosis?
Abortion?
Ectopic pregnancy.
Okay.
It could
I don't like her pressure's dropping.
it could be appendicitis. Depending on where it
In the female during childbearing years.
Yeah, but it could be a medical problem as well, cardiac.
Very well could be. Ectopic pregnancy, one of the questions that Jim had, I don't know if you heard him or not, was it what would give you the idea that it's ectopic pregnancy? And I was telling Jim it's anything within childbearing years who is sexually active with unexplained abdominal pain.
Sudden onset?
With sudden onset of pain, sharp pains. Could be a potential for an ectopic pregnancy. And sexually active, not using any forms of protection.
Urgent pregnancy?
But you could also say that'd be a cardiac. Well,
It could be, but there's other things we can rule that stuff out with.
but you're focusing on the age and saying it's probably
It could be, yes. But don't be stuck on just age. Because I've had a 19-year-old with STEMI before.
Yeah.
So the age doesn't mean anything.
Essentially, with these types of potential diagnoses, main things,
Right.
you can't do anything prior.
Get oxygen if you need to. You just had a lot of fluid loss. Days to give fluid.
Right. We can't fix it.
Right.
So we,
So again, so you want to either move quickly to the ER, right?
Yeah.
Or call for either an AEMT or paramedic assistance.
If you had an ectopic pregnancy as a medic, what could you do? Anything additional?
Maybe some pain control if they want it. All right, so ALS indicators for the GYN patient, we altered level of consciousness, if there's any altered level of consciousness there. A BP is systolic less than 90. Sustained tachycardia of 100 to 120. Pelvic pain with high likelihood of unstable condition during transport. Excessive vaginal bleeding. And seizures. Or some ALS indicators during the GYN patient. If they are seizures, what could that likely be?
Sure.
Preeclampsia.
Preeclampsia.
Right. So what's this is partially ALS? What is the treatment for seizures?
Oh, that.
Call for a medic, right?
But that's diazepam.
Treatment for seizures on a patient who is pregnant is magnesium sulfate.
Excellent.
And we're going to be giving mag sulfate versus diazepam or midazolam to treat the seizure.
Oh.
Got the future medics.
Oh.
All right. So obstetrical,
Why
these should be the best calls that you'll ever go to or go on.
Kevin.
The absolute worst nightmare you ever could imagine.
Kevin,
Yes.
over here we had a question in the peanut gallery.
Yeah.
Why Magsol over a benzodiazepine?
Why mag sulfate?
Yeah,
Because the patient has a low magnesium level causing the seizures.
gotcha.
Roger Dodger.
So we give mag sulfate to correct that. If that doesn't work, then we can definitely go towards a benzodiazepine. But usually it's because the patient has low magnesium levels causing the seizures. So some OB emergency considerations. Remember this, that when you're in the back of the ambulance or treating, you remember you have 2 patients. So history is very important. Don't forget to ask about prenatal care. 3rd trimester bleeding is not normal. So if you have bleeding in the 3rd trimester, it's a bad sign. Prepare for the unexpected. If dad is there, use him as a coach if you can. Try to listen for fetal heart tones by placing your stethoscope in a quiet location on the belly itself, and listen for some fetal heart tones. And then ask about the last time the baby had any movement or if they felt any. Now, in your 3rd trimester, the baby should be moving every 2 to 3 minutes. Should have a kick or a turn if they're not sleeping. When they're awake, they should be kicking and turning and moving. That's how you know if they're active or not. Right? So you got to ask when was the last time the baby kicked. Now, if it's been a half an hour to 40 minutes to an hour, and it's not normal, is that an emergency at this point? Yeah, definitely. Because now we have a baby that's not moving. And they need to do abdominal ultrasounds to see if there's actually any movement.
How long do in the uterus? How long do babies normally take a nap for? Like, they just rule in it wasn't that.
They can,
But you don't.
but they're gonna check heart tones, check heart rates, make sure the baby still has some movement, still alive.
Babies nap in the uterus.
Yeah, they sleep. They sleep, they kiss, and they kick, not kiss. So they sleep, they kick, they punch,
I mean, I know they kick and punch riders. I never
They
realized
dance.
they go to sleep.
they dance to music. So if you take your headphones or you put loud music and place them over the female's stomach, it actually, sometimes they have different movements.
Now
All right.
you're pregnant, baby. Try it.
Yeah. So other ALS indicators for the obstetrical patient is imminent or recent birth, decreased level of consciousness in the mother or newborn, systolic BP of less than 90 or greater than 140 systolic, 3rd trimester vaginal bleeding or pelvic pain, history of complications at birth, multiple births. Are we prepared for that?
No.
How many OB kits do you carry in Shelburne on your ambulance?
3.
2.
2 per ambulance.
3.
3. Feeding that
3.
in the truck.
So you can handle triplets on scene and call for multiple ambulances.
I was like, we don't want to. Because
Right. So a lot of people put like 1 OB kit on the truck, and what's the chance of having twins? That's it. Right. So if you carry any at all, carry 2 on your ambulance. Breech presentation is another indicator we gotta look for ALS. Prolapse from nuchal cords. Shoulder distortion. Postpartum hemorrhage. If you have postpartum hemorrhage after the baby has been delivered, we do carry at medic level, we carry Pitocin or oxytocin, 10 units we get over with a drip. That can control postpartum hemorrhage.
But a little blood is normal after.
A little bit of blood's fine. We're talking about significant bleeding that you can't control by massaging counterclockwise in the uterus. When you massage it counterclockwise, right? If you can't control the bleeding and it's still constantly bleeding, then we can give Pitocin or oxytocin and what we carry for the month on the ambulance. We just give 10 units and that'll hopefully vasoconstrict, causing the vessels to close down and stop bleeding. All right, so abruptio placenta, as we talked about here, is the partial or complete detachment of a normally implanted placenta at more than 20 weeks. This occurs in 0.5 to 2% of all pregnancies and will result in fetal death of 1 out of 400 cases of abruption. Predisposing conditions include maternal hypertension, preeclampsia, multiple births, trauma, and previous abortion. All right, so those are the things that you can look for predisposing conditions. This is kind of what it looks like here, tearing from the wall. Okay, so you can see as it tears, if you look down on the picture on the right-hand side, you're going to have a lot of bright red blood from the tearing. This will be very, very, very painful for this patient. Placenta Previa is a placental implantation of the lower uterine segment encroaching on or covering the cervix. This occurs approximately 1 in 200 to 1 in 400 deliveries, with the highest incident being in preterm births. Right, so we're sure we're asking the patient, how far along are you? This is associated with increased maternal age, multiple births, or a previous C-section, or a cesarean section, and or placenta previa. So, a good question is to be asking. Normally, when a patient has a C-section once, they're going to get another C-section again, and then again. And from what I've been told through reading and talking to other females who've had C-sections done, the most they can have is 3. After the third C-section, they can no longer have kids anymore. That's what I was told by some OB doctors and things like that. So, because you only cut in so many times. So,
Makes sense.
Yep.
So is placenta previa something that can be diagnosed prior to the baby being born?
Yes.
So they'll see it in the ultrasound.
Yes.
How do you diagnose postpartum?
In the ambulance, looking at different associated symptoms, and you have painless bleeding. Continuous painless bleeding.
Okay.
And it's also dark in color. Don't forget that part too. Yeah. All right. A uterine rupture. That sounds pretty bad, right?
Yes.
Right. So this is a spontaneous or traumatic rupture of the uterine wall. This occurs in approximately 1 in 1,400 deliveries, with a 5 to 15% maternal mortality rate and a 50% fetal death rate. So as you can see, this happens 50% of the time, so 1 out of every 2. Think about it, will be a death. The abdomen is usually rigid with diffuse pain. Fetal parts are usually palpated through the abdominal wall, right? So you're able to feel the hands, the feet, things like that as you're palpating through the abdominal area. All right, remember, we need to do hands-on assessments with pregnant females. Really doing a good hands-on assessment and palpating the abdomen area and the pelvis. All right, so scenario number 2. This is going to be for the Shelburne crew, then. What do you guys do with this one here? Dispatch a 32-year-old female, 26 weeks pregnant. She has skipped her last 3 medical doctor visits because of lack of insurance. The patient has complaining of sudden onset of left-sided, very sharp abdominal pain, and now with a bright red vaginal bleeding. What are we going to do?
So we will be obviously doing basic patient care, BSI, taking vital signs. We will be checking the opening, the vaginal opening, to see the blood flow coming out. It's bright red blood, so we need to suspect that it's pretty fresh coming out. Sudden onset of left side pain, that can be a sign of Abruptio Placenta. So we need to keep that in mind. And then probably call for a medic.
Yep, sounds good to me. What do you guys think? All right, see, thumbs going up. I like it.
So as a medic, what can you do for this patient?
Nothing. With bright red bleeding and pain, I might do an online consult with a medical doctor for online medical control, for maybe some pain meds to kind of help. My choice of pain medication for this would be fentanyl. Fentanyl will not hurt the fetus at all. It's not going to hurt them because it's such a short-acting medication, and we don't give enough of it to make a difference to the fetus. So they might get some pain meds for me, but it'll be with online consultation. I do like Shelburne's diagnosis. I think that Abruptio Placenta is probably the right diagnosis for this at this point in time. So ABC is obviously oxygen therapy. Place patient in left lateral recumbent position. Why is that?
So we're not caressing the inferior vena cava and causing hypotension.
Okay. Control any type of bleeding if they have external bleeding. If they're bleeding, vaginal bleeding, do we pack it?
No, we don't pack vaginal bleeding.
We never pack anything. Nothing goes in the vagina ever, unless it is a prolapsed cord and your hand has to enter. Other than that, we do not enter it. But again, invite the medics. They want to come play. As far as AE&T though, remember IV access, right? You get IV access established and you get fluids, okay? Because they might need some fluid replacement for bleeding. But also keep in mind that with a pregnant female,
You don't want to overload them
you don't want to overload them because how much more blood do they take on? When you're pregnant,
20 to 30%.
it's like 80% of your normal volume added on to your total. So your normal blood volume, add like another 80% to that. That's how much extra blood you have in your body to support the fetus.
A lot of blood.
But in the same token, you're still treating 2 patients, right? You still have 2 patients that you're treating. Okay, so next one is supine hypertensive syndrome, which usually occurs in the 3rd trimester of pregnancy. And it occurs when the gravid uterus compresses with the inferior vena cava, when the mother lies in a supine position. Hypotension and dizziness are usually the main characteristics of this. So you got a patient who's laying down, and they're hypotensive and they're dizzy. We need to start thinking supine hypertensive syndrome. As you can see here, the baby is pressing down on the inferior vena cava, causing a little blood flow. Preeclampsia is a hypertensive disorder of unknown origin that usually occurs in 5 to 8% of pregnancies. Are responsible for approximately 25% of all maternal and preterm fetal deaths. Associated with maternal age, chronic hypertension, renal disease, diabetes, systemic lupus, and multiple births. Eclampsia is preeclampsia that is really bad. All right? This is characterized by the same signs and symptoms as preeclampsia, but also adds seizures and coma.
Are they still hypertensive in eclampsia?
They potentially could be. You just got to take vital signs and look. But the hypertension is not so much of a concern as a seizure and coma, right? So we want to make sure we're treating for this. If you have an eclamptic patient, you want paramedics on board right away, because this is when they're going to give magnesium sulfate. It's usually 4 grams. All right, so for the Charlotte crew today, scenario number 3. You're dispatched to a dental office.
911.
All right, Jim, they're going to your office today. For a 33-year-old female, pregnant female, in active seizures.
I want a medic.
You enter the office and find the patient unconscious, unresponsive, and tonic-clonic seizures. The dental staff informs you that the patient is 34 weeks pregnant and her blood pressure prior to the dental procedure was 142/90. What are we going to do? What are we thinking is going on?
Calling a medic immediately.
All right, medics been dispatched. They're 20 minutes away.
It's eclampsia.
They've gone from preeclampsia to eclampsia.
Yep. So they're eclamptic at this point, right?
Right.
Okay. So we're going to ABCs, oxygen, place the patient in left lateral recumbent position, handle the patient gently, and minimize sensory stimulation and avoid precipitating seizures. What about a blood glucose check?
Yeah,
I would check it.
Could the seizure be caused from low glucose?
They have gestational diabetes.
Right? So get a glucose check anyways. And any type of seizure patient, whether it's pregnant or non-pregnant, male, female, doesn't really matter. If they have a seizure, we're checking their glucose anyways, right? They're getting glucose. Kind of a side note, you deliver a baby, where do you check the glucose in the neonate?
Heel.
Right on the heel. Good job. All right.
Good job.
Let's talk about intimate delivery. So crowning or bulging of the fetal head at the vaginal opening. This is our intimate delivery. We're going to, yeah, here we go. I'm going to make the delivery now.
You have the
With this are contractions that last 2 minutes, that are less than 2 minutes apart. So when we're measuring contractions, we want to know how far apart are they and how long the contractions are lasting. So the contractions, or the urge to push, and the pain lasts 30 seconds and it's happening every 2 minutes. We need to really understand this delivery is going to happen very soon. All right, if there's a contraction and 5 minutes go by, we've got time. We still have time for this. Okay, we can load them. But if there are contractions of 30 seconds lasting 1 to 2 minutes apart, prepare for delivery in the house. If they have a feeling of rectal fullness, like the rectum is full, at this point in time, the head is very, very close to the vaginal opening, ready for delivery. Feeling of intimate delivery or the need to push, especially in a woman who's had a child before.
Is it urban legend that babies have been born in toilets?
I've never seen one done before, but I can't say it has ever been done.
I've heard it just because people say, like, the females say they have to make a bowel movement and they go and somehow the baby comes
Could happen. Because anything is possible.
out. That's,
And then you talk about the water breaking. Does the water have to break for delivery?
yes.
No. Nope. The baby can still be born in the sac. If you actually read studies on this, it's actually the safest way to deliver a child. Is it still in the water sac?
How come?
Because it protects it from any kind of injury.
So is that why some women will do water births?
No. It's a little bit different. Right. If you actually look online and Google Photos and type in delivery with the water sac not being broken, it's actually pretty cool. It's like an alien photo almost. But you can actually see those online. All right, next picture here, we'll look at what deliveries look like. As you can see here, head coming out. I found out this is actually one of the newer ways of delivery, where they're standing up, bent over. And this is one of the newer ways of delivering. I've read some stories on this in articles. Yep. I told you this is scenario number 4. All right, so back to the Shelburne crew. You guys are still there, right? This is scenario number 4. This is your scenario. What do you do? Baby is born.
Oh, we can't.
What was that?
We were still reading the slide.
when you do it over there.
No, wait.
Thank you.
Now, what are you reading on this, anyways?
Oh.
No, what you're doing is you're logging in to read the PowerPoint probably.
Well, there's quite a bit of writing on the right hand of our screen. So
You guys are seeing a different screen than I want you guys to actually see.
we see 2 screens.
But that's okay, though. At least you guys have some notes to read this time. What you're
I
supposed
think.
to see on the screen is just
The picture.
the picture itself.
Okay.
All right, so you go back to the other slide.
All right, so we're back here. Now what? What do we do?
Wait, how did you go from that position?
And for takeoff.
Baby delivery. All right, so what happens now?
Well, it came out, and you clear the oral airway, the oral pharynx. First, you stimulate and drive the patient. Take your original APGAR score. Hopefully, it's good range. If it's not, then you might need to resuscitate via breathing for the child.
Yeah.
Then wait another 4 minutes and take the other APGAR at 5 minutes, and hopefully it's better. If not, you're going to just be resuscitating all the way to the hospital.
Okay. How do we stimulate?
How do you stimulate the baby?
Yes.
You take in your OB kit, or if you have another type of sterilish blanket, you grab the baby, wrap them in it, bundle them, and just hard. I wish you can see the movement I was doing. And just arms, legs, torso, be gentle on the head.
Rub them.
And rub them.
Yep, and flip the bottoms of the feet, right?
Yep.
And flip the soles. All right, so other complications to consider is a premature delivery under 37 weeks. If you have multiple births. Pulmonary embolism is most common cause of maternal death, throwing a clot into the lungs from the delivery. Excessive postpartum hemorrhage, where you cannot control that other than massaging the uterus counterclockwise, and we're calling for a medic to give Pitocin or oxytocin. Another one is the perennial lacerations. As you can see on the screen, looking at the bottom right-hand corner, where you see a little bit of bleeding, you can have some tearing there.
Can mostly.
As it's pushing through. This is a nuchal cord, as you can see here, potentially lethal. It is wrapped around the baby's neck as it being delivered. A prolapse cord occurs when the umbilical cord slips down into the vagina or presents externally, which can cause fetal asphyxiation. This occurs in approximately 1 in every 200 pregnancies and should be suspected when fetal distress is present. The most common is with breech presentations, premature membrane ruptures, large fetus, a long cord, multiple gestation, or preterm labor. So some things to think about when you see these types of presentations when we're working on a delivery. Normally, like I said, if their first delivery was a breech, most likely the second, third, and fourth, if they decide to get pregnant that many times, will also be breech births. Something to think about. So always ask about the history of breaches. So who did their last one? I think it was Shelburne. So Shalakri, you were up. That's scenario number 5. We're almost done. Dispatch to a 28-year-old female, home alone, first pregnancy, no previous pregnancies, with good prenatal care. The due date is greater than 2 weeks. Mother is in good medical health. She was on the toilet when she felt an urge to bear down. Her water broke, and she discovered the following. What do you do?
Got nuchal cord.
Nuchal cord.
Beat you to it.
I said it was nuchal cord way before
It
you.
takes us like 30 seconds to unmute ourselves.
Yeah.
I like it. I love the battles. All right. What are you going to do? What are you going to do for this patient?
Oh, transporter.
Rush them to the hospital.
Diesel.
Wrap the cord in moist.
Yeah. Okay.
Or not.
Wrap the cord.
Any bleeding.
Wrap the cord. Wrap the cord in moist sterile dressing.
Moist sterile dressing.
Is there anything we can do?
Insert your hand.
Oh, and
Yeah, you can insert your hand and create an air pocket for the child, right?
yeah.
To breathe. So you're going to place 2 fingers in the vagina to relieve pressure off the cord and raising the fetus off the cord. This will allow the infant to hopefully still have a good pulse and still be able to breathe appropriately. You're going to check the cord for pulsations. Okay, you want to make sure that there's good pulsations going through the cord. Put the mother in a knee, chest, or hip elevated position for this. Do oxygen therapy. Transport the patient, keeping the pressure off the cord. So when you put your hands in, they may be in for the ride. Okay? Transport, keeping the pressure off the cord. Moist dressing to the exposed cord, and do not push it back in, please. Right? Please don't reinsert stuff and push stuff back in. It's a bad idea. Right? And all ALS. Breech presentations, 3% of all presentations will be breech, either limb or buttocks, or more common in the premature infants and with uterine abnormalities. The increased risk for fetal trauma, anoxia, and prolapse cord.
So
For breech.
if they come breech, we can't birth them though, right?
Correct.
We have to put them in the ambulance and go.
That is correct.
The only thing we can birth is a perfectly good, healthy.
Correct. Yeah. These are different signs of breech. You see the breech in the top, or the knees, or the leg. Please do not take your hand and shove limbs back inside. Okay? Just transport fast. All right. So Shelburne, you guys are up this time, right? Yes. Scenario number 6. Dispatch to a 37-year-old female, non-English speaking, unable to ascertain any medical history due to a language barrier. One of the many midwives in attendance states that the mother has been in labor for a very long time. You walk into the house, you can find the mother in complete state of exhaustion leaning over the couch. What do you do?
Does the midwife speak English?
Yeah, a little bit.
Well,
This is what you see.
What?
bummer.
Is there any male presence in the home?
What was that?
Is there any male presence in the home?
Not that's what's listed.
Okay. If there's no male presence in the home, and both if the patient is willing to be transported up to the hospital, we get on our stretcher, make sure we kind of stabilize the baby as it is, maybe put a pillow or something under it so it's not causing extra stress on the female. Do not let her keep pushing, or else we're going to have an issue with the head getting stuck or the shoulders, which can cause either bleeding or just can be harm to the baby.
I think baby's already stuck.
Diesel to the hospital, vitals, normal stuff.
I'm confused.
Left lateral coming, baby.
All
How do
right.
you feel about that?
Sounds good. What are you confused about?
It looks like the baby's like basically out.
Yeah, but she's going to be stuck now by the arms and shoulder because the cervix can't dilate anymore. It's stuck right there.
It looks like
Come out, but the head might not. And then it
Right.
pulls out.
So as far as patient care goes,
Decapitated kid.
place the patient in knee chest position with buttocks or with the buttocks on the edge of the bed, legs flexed as much as possible. Instruct the mother to pant with each contraction to prevent bearing down. Allow the infant to be delivered with contractions and apply pressure at the pubis as the head passes to support the baby. So we can try to make an attempted delivery if we need to at this point. Moist dressing to the cord to prevent umbilical artery spasms. Your gloved hand to prevent the delivery if unable to deliver in the field, and relieve pressure from the cord. Obviously, you want ALS on board for this. Okay?
Is there a name for that position?
It's just breech.
That's the breech.
Yep.
What do you want next? Who gets the
Right. This is how you do delivery. So as you can see, they're pushing down on the lower part of the abdomen with their hand to help assist the delivery and change the position of the baby to deliver the child. And the other hand goes in as you support coming out. So these type of deliveries can be done in the field if most of the limbs are present and she feels the urges to have to push. The thing is, you can't hold it back from coming out. She's pushing it, she's pushing. We still have to assist in the delivery. Not a bad time. Let's say since Shelburne has this call here, let's say you go mutual aid divergence. Can that happen?
Can we be called to mutual aid and divergence?
Yeah, we've gone to pant.
Yeah, that is true.
Okay? You call and you see this.
Yep.
You got a long ride ahead of you still, right?
Yep.
The best thing to do for the situation, if you feel uncomfortable with the situation going on, obviously call for ALS. But the next
Probably
what I would do if I was
what
a EMT or an A, I'd put the phone on speakerphone and get med control and talk you through it.
Yeah, I would definitely try to, if it was just the shoulders down, it was just the head in, I would try to do it on scene and probably call for ALS. But if the shoulders were still in, I would try to get the mother and child on the stretcher and get going and meet ALS en route. And then, or do the medical direction and keep them on the phone to walk me through it.
Yep, medical direction if you need to, though. It's keep them, like Mike said, keep them on the phone. And they'll stay on the phone as long as you need them. So,
For gens and you get this, would you consider going for Porter just
No.
because it's closer?
not at all.
Why is that?
Because this is not a normal birth. And you want to get them to a place that can handle anything premature or anything else like that kind of complication. All right, so we're almost done. Shoulder distortion, which occurs when an infant's shoulders are larger than its head, most common with diabetic or obese mothers. Labor progresses normally through routine head delivery, which will then retract back into the perineum because the shoulders are trapped between the pubis and the sacrum. As you can see here.
The baby's turned weird too, it looks like.
Yeah. So scenario number 7 for the Sherlock crew is dispatch to a 29-year-old obese female, full-term pregnancy, delivering at home. A patient without constant prenatal care and 3 previous births. In labor for over 3 hours with father assisting delivery. 911 was called when the father realized the baby's head was stuck. What are we going to do?
Possibly call for lift assist too. You're not sure if your crew can handle it.
Okay, so you call for a lift assist. We got to treat the patient now, though. The baby's head is stuck. What are we going to do?
Manage the patient and get in the truck and go.
You gotta be careful about.
Yeah. We're going to have to get the shoulders through somehow, right?
Right.
Perfect. Let's talk about it.
Boy.
So you're going to take out one shoulder at a time, utilizing the head. You're going to do the anterior shoulder first. Sorry, you're going to do the posterior shoulder first. And after the posterior shoulder is through, I think I did that backwards. Sorry, anterior was first, posterior second, as you can see. So you have the head coming down and then coming back up again. You're going to try to assist each shoulder separately instead of at the same time.
This is BLS?
Yep. You're assisting in delivery. You just got to know come down first, and then bring the shoulders back up to kind of support it going through. Please do not pull the baby's head. You don't yank out, right? Oxygen therapy, have the mother flex the thighs to assist in delivery. Remember, flex. Apply firm pressure with your open hand above the symphysis pubis. Apply firm pressure, right? And call for ALS and oxygen and transport. As far as shoulder presentation goes, the fetal shoulder lies over the pelvic inlet, and spontaneous delivery is not possible at this point in time. And delivery of the fetus through cesarean only. There's shoulder presentation first. Position of comfort, oxygen therapy, rapid transport, call for ALS. Postpartum hemorrhage. As you can see, if we have postpartum hemorrhage, we're going to place a hand on top of the uterus. We're going to apply pressure and rotate hand in a counterclockwise motion to hopefully control the vaginal bleeding from postpartum hemorrhage. Please do not force delivery on the placenta. Do not pack the vagina with dressings. That also means do not pull on the umbilical cord to pull the placenta out. It will deliver on its own when it is ready. And or they have to go in and remove it surgically at the hospital. Uterine inversion is a rare event, but in which the uterus turns inside out after birth. Even note that hypovolemic shock may develop very, very quickly in this patient, so make sure that you have bilateral lines in place and fluids running. Do not attempt to manually replace the uterus. ABC is oxygen therapy, and again, call for ALS, especially if you're at the ENT level. This patient's going to need an abundance of fluid to keep out of hypovolemic shock. Fetal membrane disorders were premature rupture of the membranes, or an amniotic fluid embolism, or meconium staining. So neonatal resuscitation, some of the basics: open the airway, prevent heat loss, provide tactile stimulation, evaluate the infant with an APGAR score, and invite ALS. So if you have a neonatal patient who is now in cardiac arrest, what is our compression to breathing ratio?
3 to 1.
3 to 1. All right, so it's different than what we learn in class, right? We learn in class to deal with pediatric, child, and adult, right? Infant, child, and adult. Infant is 15 to 2 or 30 to 2, depending on 1 or 2 person CPR. What they don't teach you is neonates. And neonates is a 3 to 1 ratio, 3 compressions, 1 breath. And that's within your protocols for EMS. So remember the 3 to 1. All right. This is your APGAR score here. Appearance, pulse, grimace, activity, and respirations. Appearance scores from a 0 to 2. So the body is completely pink, it's a 2. The body is pink with extremities are blue, it's a 1. If the entire body is blue, it's a 0. as far as your response to stimulation, your grimace and activity is a score of 2 is vigorous and crying. Mild grimace, only upon stimulation is a 1. Unresponsive is a 0. And this is the last scenario. So you guys are working this one here together. As you're dispatched to a 40-year-old mother, infant childbirth. Patient is full term with 3 previous very quick deliveries. And route dispatch informs you that the baby is crowning. As you walk in, you find the mother has already delivered the baby. What are we going to do?
Was it an intentional home birth?
Probably not. Perfect. What else are we going to do, children?
I think that depends on what mom and baby look like.
Fair enough answer. All right. We'll see what we're going to do more resuscitation here. So we're going to prevent heat loss and keep the baby warm, right? Airway. Open airway, side or back position. Suction airway with a bulb syringe. Why do we do the mouth first versus the nose?
Because you're mouth breathers.
Because they're mouth breathers?
Because they breathe through their mouth first.
Yep.
Reevaluate infant's respiration, heart rate, and color. So remember, keep doing your after-hour scores. Score your O2 and BVM. And do not hesitate to call your friends, the medics. All right, so that's the end of the presentation. Do you have any questions at all? Okay, so.
One question. How do you transport newborn?
Depends. Me personally?
Yeah.
With mom.
In mom's arms?
Yep.
Can we legally do that? Not simple.
We're not seatbelted in.
Right.
Would you have a child seat big enough for a neonate?
So if they have, let's say they have a car bed or something to transport them in, would you bring that and use that?
I would put it right with mom. Because they're going to stay warm
Right.
and they're going to start feeding.
Okay. Just keep them warm.
Yep. What document is such? Right, Mike?
Yes. Again, Jenna, you bring up the point of that, but there's more benefits of having the child on the mother, wrapped in a blanket, warm, causing that oxytocin for the mother because of the skin-to-skin contact,
And the
and
baby.
seatbelted in. And again, I understand with the Vermont protocols and transport, we got to be careful transporting kids. But babies are that one rare issue, the newborns, where they don't really fit in anywhere, especially if they're delivered on scene. How is that for an answer? Any questions on that answer?
I like it.
No, that's good.
But documentation and why you did something was a longer way than not documenting at all and getting in trouble for doing what you did.
Correct.
All right. So that is the end of the slideshow. So the only thing I ask, if you want credit for this class, I'll give you guys the 2 hours of credit is log on to the cvfrs.com, go to the rescue tab, click on EMS monthly training, type in the EMS password, so it's capital E, capital M, capital S, then lowercase training. It gets you into the training portal. Look at ALS monthly trainings, click on the OB quiz, take the quiz, hit submit, and once you submit it, for the Shelburne personnel, I'll print out certificates for you of completion. For the class, for your national, for the once you're in Charlotte, I will do a roster here and put you into the schedule system.
Do it out of that form.
Yes, ma'am.
So, other than that, any other questions at all before I stop recording?
No questions.
All right, once you guys hang on a second, we'll discuss this really quickly after. Let me just stop the recording here.